Hello, everyone. Thank you all for joining us tonight. I'm Hannah Collins, and we're here with Dr. Reid discussing sleep apnea. I'm going to introduce him, and then he can go ahead and get started. Dr. Reid is a college graduate of West Georgia, where he received his BA in biology. He then went to Mercer University School of Medicine in 2000. Dr. Reid completed his internship and residency in internal medicine at UAB, along with his fellowships in pulmonary medicine, critical care medicine, and sleep medicine. Dr. Reid is a board certified in internal medicine, pulmonary medicine, critical care medicine, and has 2 certifications in sleep medicine. Dr. Reid has been practicing in Carrollton in a private practice, focusing on all the above specialties since 2007. He is also a medical director with Tanner Medical Center in Carrollton's critical care unit, as well as a medical director of the sleep centers from Tanner Medical Center in Carrollton, Villa Rica, and East Alabama. Dr. Reid has been married to his wife, Tina, for 28 years. He met Tina when he was a freshman in college while holding a position as a patient tech at Tanner Medical Center in Carrollton, and Tina was also a ward clerk. The 2 of them now have 2 children and live in Carrollton. Dr. Reid, you can have the floor.
Okay, thank you. Well, welcome everyone, and thank you for joining us so we might can share some information about sleep apnea tonight. So we'll go ahead and get started. Hopefully you see the instructions here on how to ask a question. So first, let's talk about what is obstructive sleep apnea. So sleep apnea is really, it's defined by either pausing in your breathing or actually stopping breathing, shallow breathing during your sleep. It lasts, by definition, has to last at least 10 seconds each event. And it can happen really hundreds of times per night. I saw a sleep study just this evening where the patient stopped breathing about 500 times in their sleep in one night. And you can imagine that causes a lot of sleep disruption. It's typically associated with snoring and sometimes these sort of choking sounds. Not always, but most of the time it is. So adults commonly have really severe daytime sleepiness is a common side effect, although a few people do not have daytime sleepiness. Children have the same syndrome oftentimes, and they tend to have the opposite of daytime sleepiness. They have hyperactivity as a symptom, and oftentimes that's why we study kids to look into their hyperactivity. They try to sort of be hyperactive to prevent them from falling asleep. So when you look at how much sleep apnea is out there, and we're just talking about people with sleep apnea bad enough that it needs treatment, it's about 22% of all men, of all adult men. About 12.5% of females also have treatable sleep apnea. So this is kind of a funny looking slide, but this is a way that we sort of grade airways in whether we're talking about sleep apnea and sleep medicine, or your anesthesiologist when you have a procedure uses this same scale. And we won't talk in any detail about this, but basically sleep apnea is a problem with crowding of the airway, particularly back here behind the tongue. So you may see in this, what you see this class 1 airway, when you say ah in the mirror, you can see all of these structures back here and see the open airway, all the way up to this sort of class 4 airway you might see on the screen, where they say ah and you really can't see any of the structures and you see no airway. That class 4 and class 3 really predicts that you could have sleep apnea. It also predicts to your anesthesiologist or your pulmonologist that they might have trouble getting a tube down in your airway for a procedure. So again, this whole problem exists really within the neck and the posterior, behind your mouth, behind your tongue, what we call the postpharyngeal structures. This is another way of looking at it from the side that probably makes more sense. But as you can see, the tongue on this image, the tongue that we see when we stick out our tongue is only a very small piece of our tongue, maybe 10% of our tongue, but the tongue base is a very large structure. You can imagine when you lay back flat and you go to sleep, some people, that will actually block off the airway, as you can see on the right. So that's why sleep apnea is also much worse if you're laying flat on your back. And most new sleep apnea patients I see that I suspect have apnea, oftentimes I'll tell them when we ask about how they sleep, how do you sleep on your back? They'll always respond, well, I don't really sleep on my back. I don't sleep very well. That's because they've learned that laying on their back is where they're going to have the most events and get the most sleep disruption. Because every time you quit breathing, you literally have a brain arousal to wake you up. For 2 or 3 seconds, you wouldn't know it happens, but you can see it in the sleep study. But they literally wake up oftentimes hundreds of times a night, which obviously can lead to a lot of sleep disruption and daytime sleepiness. Sometimes they're only effectively getting a couple hours sleep, even though they're in the bed for 8 hours. So hallmark symptoms there, really the hallmark symptom is probably snoring and gasping in your sleep. A bed partner will always say, hey, I see you, quit breathing in your sleep. Daytime sleepiness, again, is very, very common and has a lot of problems. The daytime sleepiness can make you not very productive at work. It can give you that sort of brain fog sensation, make you much more likely to have an auto accident, up to 7 times as likely to have auto accidents. Restless and what we call non-restorative sleep, meaning I slept 8 hours, why do I get up feeling like I'm ready to just go back to bed? Vivid dreaming, you can also see people who don't dream at all though. Insomnia, in that they just keep getting woke up. You see people routinely who are getting this minor arousal or waking up every few minutes all night long, and for some reason the brain at some point says no more, and it's just going to keep you up for a while. And people will say, well, I don't sleep that well, but I wake up and at midnight or 2 o'clock and I'm up for 45 minutes and can't go back to sleep. Finally, I go back to sleep. That's a common complaint with sleep apnea. Morning headaches is a problem too. These people, they breathe so shallowly that they accumulate carbon dioxide, which causes brain vessels to kind of dilate, and they'll oftentimes complain of morning headaches, usually in the front of the head. Mood disorders, whether we're talking about anxiety, depression, other mood disorders, are also oftentimes linked to sleep apnea and sleep disruption generally. Cognitive decline, so just again, not feeling quite as sharp at work, not feeling quite as sharp when they're driving, so auto accidents again. And nocturia, which is just having to get up and go to the bathroom a lot at night. There's a mechanism whereby your heart puts out a hormone due to the sleep apnea. The heart thinks it's got way too much fluid, and it puts a hormone out to your kidney that encourages your kidneys to make urine all night. So lots of people have to get up and go to the bathroom a lot more than they otherwise would, and sometimes that completely goes away with treatment of their sleep apnea. So the major risk factors for sleep apnea, number 1 is obesity. Neck circumference is a common way we start to judge. Females with a neck circumference of 16 inches or greater typically will have sleep apnea, or at least often have sleep apnea. With men, it's 17 inches or greater typically have sleep apnea. Age is an issue. As we get older, you're more likely to have sleep apnea. Male gender, men are more likely. You saw we were talking about 22% of men, maybe 12% of women. So males, it's more common in males, but I will say at menopause and postmenopausally, the rate of sleep apnea in females catches up to the rate in men. Craniofacial abnormalities, so facial trauma and injury can promote it. Some craniofacial differences, like you might see with Down syndrome. We have lots of patients with Down syndrome who oftentimes have very severe sleep apnea, and just a crowded airway like we showed in the images earlier. So associated conditions, so hypertension, very much believe that hypertension can truly be caused by sleep apnea in some people. And that's fairly firm in the data that it can truly cause that. We know it increases the risk factor for cardiovascular diseases. So for sort of, heart attack, heart blockages, rhythm problems, atrial fibrillation. We know all these things are related. We don't know if there's a true cause there, but they're certainly very related. Cerebrovascular disease, particularly stroke, and then those who've had strokes are about 70% of people who have had a stroke end up with sleep apnea from the stroke because it affects the tone of their airway. People with pulmonary diseases like COPD in particular are much more likely to have sleep apnea. Obesity, hypoventilation syndrome just means people can have such morbid obesity that they don't ventilate properly even when they're awake. Well, they have a lot of trouble in their sleep with sleep apnea, and it's pretty much ubiquitous. They all have sleep apnea. There's an association with diabetes, and it doesn't cause diabetes. Nobody else, I believe, thinks that, but people with diabetes definitely show worse glucose control, worse sugar control, higher sugar numbers if they have untreated sleep apnea. People with ESRDs, end-stage renal disease, but dialysis, those patients on dialysis tend to have a much higher risk for sleep apnea. Anybody who has a lot of fluid overload and extra fluid in their body, very high risk for sleep apnea. Pregnancy is also a major risk factor, and we routinely put pregnant females on CPAP. That's a very common thing. Thyroid disease, particularly low thyroid function, is also very strongly related, particularly in females, but we see many men and diagnose a lot of men in the clinic with thyroid failure based on them presenting with symptoms of sleep apnea. Reflux, GERD, gastroesophageal reflux disorder. So reflux, heartburn also can really be driven by these apneic events in your sleep and sort of this struggling to breathe, change in pressures between your chest and your abdomen, and can promote a lot of nocturnal reflux. NAFLD is basically non-alcoholic fatty liver disease. You may have heard someone who has a fatty liver. Believe it or not, there is some link that's been made now with fatty liver. Even when you control for obesity, there still is a prevalence of fatty liver amongst patients with sleep apnea. This is just a way of sort of how we look at, you may have seen this questionnaire in a doctor's office or in a magazine. It's called the Stop Bang questionnaire. So this is just how we get an idea about patients. We have everyone fill out one of these, and it gives us a little heads up sometime about what their risk is for sleep apnea. So do you snore? Are you tired? Do you feel tired, fatigued, sleepy during the day? Has anybody seen you quit breathing? Has it been observed? Are you treated for high blood pressure? Or is your BMI over 35, which is moderate obesity? Are you older than 50 years old? Do you have that neck size component? So again, for men, 17 inches, for females, 16 inches. And gender, are you a male? It's just more likely. So you collect points as you collect yes there, and you can see you've got a low risk if you're two positive answers or less, and intermediate if you're 3 to 4 questions, a very high risk if you're 5 to 8 questions. So that's something you can always look up if you want to try that on somebody. Just Google Stop Bang and it'll pull that questionnaire up easily. Other signs and symptoms, once again, snoring tends to be pretty much ubiquitous. Most people are going to have that, gasping and choking, restlessness during the night, waking frequently at night for no obvious reason, morning headaches, daytime sleepiness, including falling asleep at work. I see that routinely, people who are about to lose their job because they're being caught asleep so much, falling asleep driving, mood swings really due to sleep deprivation, and cognitive problems, again, probably due to sleep deprivation. When we do a sleep study, so there's a couple different ways we would commonly do a sleep study, particularly when we're just looking for sleep apnea. We do that typically at night during a patient's normal sleep hours, although we have people who work night shift, and we do day studies for those people. You're monitored by a sleep technologist. If you do this in our sleep lab, we'll talk about that first. If you come to the sleep lab and you spend the night with us, which is the most sensitive way to really look for sleep apnea, you're monitored all night by a sleep technologist. After we hook up several monitors to you that tell us about your brain activity so we can prove you're awake or asleep. And we look at your respiratory effort. Are you trying to breathe? We look at airflow. We look for different movement problems as well. There is audio video that's very, very private, and that's not something that's really reviewed unless there's something, sleepwalking, sleep talking, unusual sleep movements. And we read the sleep study just a few days after that's completed. Now, some people who are otherwise very healthy, it seems to be really the only problem they might have is sleep apnea, or we're not worried about any other sleep issue. We can do home sleep testing, which is pretty easy. We make an appointment to the sleep lab, not to spend the night, but you come in and meet someone who will show you how to use this little device, send it home with you, bring you back the next day. And if you have sleep apnea, we can also get you on potentially CPAP or whatever therapy based on that. So the home testing, again, we're really just looking for plain obstructive sleep apnea, okay? Other diagnoses, again, workup of insomnia, narcolepsy, limb movements, other parasomnias, movement disorders, dreaming disorders. It's not helpful there. In those more complex issues, we have to do a sleep study where you spend the night with us. Central sleep apnea is a little different type of sleep apnea. So this is one where you don't block off your airway, but rather your brain, which should give you a rhythmic a stimulus to breathe, all of a sudden it just stops giving a stimulus and your airway's wide open, but there's no breathing because you're not receiving that stimulus from your brain. Those people are more complex and we have to study them in the sleep lab so we can really know what's going on and really know how to fix them. And that central sleep apnea in particular is much more common in people with heart failure. That's probably the number one reason we see it. People with neuromuscular diseases, common things like multiple sclerosis, Parkinson's disease, or strokes, those patients can have pretty profound central sleep apnea. And people who use particularly long-acting opiates, things like MS-Contin and OxyContin, long-acting pain medications can develop profound central sleep apnea. Those are people we're going to study them in the sleep lab rather than doing a home study. This is just an example here of a typical sleep study. This is actually just an excerpt from a home study that's pretty interesting. If you look at the top line, the dark blue line, that's actually snoring. As you see, it's not happening very often. The reason it's not happening very often, if you look at the second line, that's the patient taking breaths. Each peak is a breath. Well, you notice this patient's taking about 4 breaths, and then they go without breathing. If you look down at the next line for as long as, 39, 30 seconds, 31 seconds. So they're breathing about 30 seconds at a time, and then, they're not breathing for about 30 seconds at a time, and then they take about 4 breaths, and they go right back to not breathing again. So if you look at the red marks here on the third line down, that we've scored that as an obstructive apnea, and the reason is that line is actually chest and abdominal movement, which shows us you are working to breathe. But if you look at line 2, it's a flat line because there's no airflow. That's looking at the airflow. So we know you're trying to breathe, but there's no airflow. With the central sleep apnea I was talking about, it can look just like this, where the brain doesn't give you a stimulus to breathe. The difference is that red mark there would say central apnea, and that would be a flat line on the effort portion. Because we see the abdomen and the chest, they're not moving, they're not doing anything. So we'd see a flat line on line 2 and 3 for central. But this is the typical look here where we see this flat line on line 2, but we have this wavy line that shows you're working to breathe on line 3. That's classic obstructive sleep apnea. If you see the numbers below it, the line with the numbers on it there, that are going from about 90 some odd to 80 some odd, or even down to 73 there, that is your oxygen levels there. And if I remember correctly, this may actually be from my own sleep study. I've been on CPAP for years. So, and you see this is heart rate on the very bottom down here. So it's very apparent even with a home sleep test, which is a really sensitive way to look for this. Different therapy treatments. So by far and away, the most common therapy we would use would be CPAP. So CPAP is really a pretty simple mechanism, and it just gives you a positive airway pressure. If you took a balloon out of a bag and that balloon would be totally flat, and if you took it out and if you just blew into that balloon just to the point that it blew up, you wouldn't have to keep blowing to hold that balloon open, right? You just have to keep that pressure constant. That's what the CPAP does. People think the CPAP is just blowing like crazy all the time. It's not. It opens the airway and then it maintains a pressure to hold that airway open. So CPAP tends to be very quiet. People think it's something that's really loud. It's actually very quiet. So it basically just increases the pressure in the airway to hold your airway open. And so you don't stop breathing because your airway's not closed, and you can't snore with proper CPAP. BiPAP is just a little different way. It's basically a CPAP with 2 pressures. So this is for people, particularly we have people with lung disease who feel like they can't exhale on CPAP, and people who require really high pressures on CPAP. Those people like BiPAP better because BiPAP is going to give you that CPAP pressure to hold your airway open, but then it's going to give you a second pressure, and each time you take a breath, it's actually going to help you take that breath, but it's going to keep that CPAP pressure always at baseline, so it prevents the apnea as well. And we do several other types of sleep studies also for different complex issues in the sleep lab as well. I would mention there are other treatments too that are less commonly used, but for some people they're the right thing. There are surgical treatments for sleep apnea. There are oral appliances, which is basically a mouth guard of types that your dentist can tell you if it would be right for you or not. It's not considered first-line therapy because it does not typically completely get rid of sleep apnea, which CPAP does if it's well tolerated and used. But oral appliance for some people is another alternative. And there's a few other things in the pipeline that are not necessarily ready for prime time. So Tanner Center for Sleep Disorders. So we've got a full sleep center in Carrollton, Villa Rica, and Wedowee, Alabama. We're accredited, all of our centers, by the American Academy of Sleep Medicine. We do full night diagnostic studies, and we do split night diagnostic studies. That's where we do half the study. We prove you have sleep apnea, and we spend the other half of the study with CPAP on you to prove we can fix it. And we also do other advanced testing for things like narcolepsy as well. When you look at the rooms, they're really very gorgeous rooms in all three facilities. It's really, Tanner's done a beautiful job. The physical plant is really a nice place. So as you can see, it really just looks kind of like a hotel room. It feels like a hotel room. It doesn't really feel like something medical. So it's very hotel-like, cable TV and that sort of thing. Small beverages and snacks. They have to be caffeine-free. Private bathroom in each room, very nice, and really nice beds there as well. So here, for more information, you can call here or go to tannersleep.org. And if you all have any questions, I'd be happy to take those questions.
Dr. Reid, this is Hannah. You did have a couple come through.
Okay.
The first one was, what are the health risks of mild sleep apnea?
So mild sleep apnea, we would define that as somebody who quits breathing 5 to 15 times per hour, technically, is mild. And, you know, as far as we know, there certainly are health consequences, but again, the magnitude of your sleep apnea is going to make a difference on how big a deal that is. So severe sleep apnea obviously is going to be a bigger deal. Mild sleep apnea is something that we know if you have high blood pressure, if you have insomnia, if you have a mood disorder, we know it can improve that. If you have daytime sleepiness, it's really interesting. You see some people with very mild sleep apnea who have profound daytime sleepiness, which totally goes away on CPAP. You see other people with very severe life-threatening sleep apnea, and they're not sleepy at all, and they think they sleep fine. And it's really tough because it's hard to get that person to use their CPAP, right, because they feel great. So it doesn't always correlate, but it's really based on symptoms. So mild sleep apnea in somebody who's otherwise healthy, either CPAP, which most people will like, even at a mild level. But in some of those patients, if they're overweight, weight loss is appropriate, and what we call positional therapy, which is a fancy way of saying don't sleep on your back. Sleep on your side, sleep on your stomach is fine. Sleep apnea is always going to be even milder there. And when we do your sleep study, we actually try to encourage people to sleep on their back so we can see how bad it is. Because even people who say they don't sleep on their back, I'll routinely see will spend 4 hours of the night sleeping on their back when they think they don't. So mild sleep apnea, again, if you've got high blood pressure, heart disease, excessive daytime sleepiness, you really ought to be treated. If you're not very symptomatic, weight loss and simply avoiding sleeping on your back is oftentimes an option.
Okay, another one that came through was, if you're an avid caffeine drinker, can this worsen your sleep apnea?
No, I don't think there's any clinical trials that show that caffeine really worsens your sleep apnea. You know, my question would be, if you drink so much caffeine, is it really because you're kind of feeling fatigued and sleepy? Could it be from sleep apnea? But caffeine itself, you know, we don't know of a lot of harmful effects of caffeine, except it can cause insomnia in some patients if they're drinking it late, obviously. It can, in some people, promote, you know, fast heart rhythms and some other things like that. But for most people, caffeine's probably not a big issue. But caffeine in of itself won't cause sleep apnea. But it would make me question, you know, are you drinking that much caffeine because you actually feel normal when you're on caffeine because you're fatigued and sleepy otherwise? And could that be from sleep apnea?
Okay, now you're getting some questions about CPAPs.
Okay.
How often should you replace your CPAP machine, and do they need to be replaced?
So the CPAP machines are pretty well made nowadays. So most insurers, including Medicare and Medicaid, plus obviously commercial insurers, most of them will replace your CPAP after 5 years. Not all of them, but most of them will after 5 years. Now, I have patients that love their CPAP and they've been on their machine for 8 to 10 years and their machine's working great. You know, if you're not snoring on your machine, that's oftentimes people say, hey, I'm starting to snore on my machine. That's because the pressure's being eroded. It's not providing the pressure that you set it at anymore. So now you're obstructing again at that lower pressure. You'll see that warning on some people. They'll say, I'm snoring again, or I'm getting sleepy again, or I'm just not sleeping as well. That may mean that machine's getting pretty old. The other thing is the machine itself has a maximum amount of hours on it. It's many thousands of hours, but it will actually bring up a warning to you, hey, your machine's outlived its lifespan. You need to get it replaced. But for a patient who's had a machine for 5 or 6 years, if they love their machine, it's working well, they're doing great, having no issues, you certainly don't have to replace it. But if you start having problems again, most insurers after 5 years will replace that for you as long as there's a problem with the machine. Medicare actually won't replace the machine unless we document there's a problem with the machine.
And somebody else also asked, do you have to sleep on your back with a CPAP?
No, absolutely not. So, you know, sleep apnea is at its worst on your back. And we encourage people during the sleep study to sleep on their back, but only because we want to see how bad is it and can we fix it on your back? Because again, people who say I never sleep on my back, most of them do sleep on their back quite often. They don't really realize it. But you do not have to sleep on your back. I sleep on my stomach every night, and I wear a big full face mask over my whole face. You know, I can sleep on my side, on my back, I can sleep in any position, but many of my patients sleep on their stomach, sleep on their side, or sleep on their back. So you certainly do not have to sleep on your back whatsoever.
All right, and somebody else also asked, is getting a referral from your PCP recommended or necessary?
For almost all insurances in this area, including all forms of Medicare and Medicare replacement plans, no one requires a referral that I know of. Every now and then, I think maybe I'm trying to remember Kaiser. So Kaiser Permanente. So Kaiser, y'all know, is kind of an HMO. Most of those folks seem like they come from the Douglasville area, but I think Kaiser does require a referral, but we see almost no Kaiser patients. So generally, absolutely not. You don't need a referral.
And the last question is, do you have to have a referral to receive a sleep study?
No. So usually you wouldn't have to have a referral to see us. Again, and you could come see us, we can order the sleep study, but your primary care physician also can order the sleep study. That's not a problem at all. Oftentimes we read that study and then you follow up with your primary care physician, or oftentimes if that study's positive, then your primary care physician will end up sending you to us. That happens a lot too, but you shouldn't need a referral of any sort. I would say one thing, we do live in a world with some pretty tricky insurance issues. But the one place things do get tripped up sometimes is, for instance, you could call your primary care physician and say, hey, I'm having trouble sleeping. I think I got sleep apnea. Will you order a sleep study? They might order a sleep study. Well, that might get done, but then it may all get denied in the end because it has to happen in this order. There has to be a face-to-face visit with a clinician. It could be your primary care doc. It could be with us. Either one's fine. But they have to document on a face-to-face visit, they think you have sleep apnea and here's why I'm doing the testing. So that's the first box you have to check. You have a pre-testing face-to-face visit about sleep apnea. Then the second thing's got to happen, you got to do a sleep study, and it's got to be appropriately scored and read, and you got to qualify for CPAP. Then the third step is you pick a provider to provide you with a CPAP. There's one provider in Carrollton, there's several in the area. Otherwise, that provider then also has to get a prior authorization from your insurance company to pay for the CPAP machine too. To get that done, you have to have that face-to-face visit. You have to have that properly scored sleep study and all that. So the insurers are very strict on that happening in the correct order. Otherwise, they can come back in the end and go, you get to pay for it all. So you just want to be really careful in getting your sleep study, because what we do, like I say, what happens is somebody just orders a sleep study, they never documented anything about the need, it all gets denied in the end. So make sure you see your primary care physician, your cardiologist, us. Any of us are happy to order the sleep study, but there's got to be a proper face-to-face visit documenting the need for that study.
All right, Dr. Reid, that's as many questions as we had come through, but thank you for joining us tonight.
Absolutely, my pleasure.
And thank you all for joining us for tonight's class. We appreciate it. Please continue to check out our classes on tanner.org, classes and events for other informative topics that are coming up. We have one on COVID next week, and then the next week is over women's heart health. And we hope you all have a wonderful evening.
Thank you.